increased overstimulation. No bright lights, okay? No loud noises. And you have to touch the baby, but excessive holding is not a good thing. Okay, what else can we do? Swaddle the baby, a pacifier. All right. Now, is there anybody in here from the Leche League? No Leche people? Because I know Leche would cut my head off for saying this. I love pacifiers for meth babies. I know that there is data to suggest that pacifiers interfere with breastfeeding, but number one, very few meth moms who are actively taking meth are not going to be breastfeeding. And you're not going to allow them to breastfeed anyway because meth crosses the breast milk readily, and there are cases of death of the infant after breastfeeding within minutes to hours after taking, if the mother's taking it, you know, methamphetamine as she's breastfeeding. But pacifiers do two things. First of all, a pacifier increases chemicals in the brain which reduce the stress on the baby. Number two, and this is incredible, pacifiers keep the tongue thrust forward, which keeps the airway open. Studies now show, not only in meth babies, but babies in general, that a pacifier decreases the incidence of sudden infant death syndrome by 61%. By 61%. So you gotta have a pacifier. It's one of the greatest tools to handle meth babies. It really does work. If the baby's not eating, you increase the caloric feeds, and that may mean, again, frequent awakenings, or you increase the concentration of the formula. But you can only do that so much because if you give them high-calorie formula, they could develop an osmotic diarrhea. So you're limited. Appropriate nipple. Again, a lot of preemies can't take that term baby nipple, and meth babies generally, or sometimes, have incoordinated suck. So we want to be sure that the nipple's appropriate. Frequent awakenings, and then as a last resort, tube feedings. But I have to say, if your meth baby is a couple weeks old and you're still tube feeding them, they've taken a neurological hit. So that is something that we don't like to see. For the baby versus food, meth baby that are eating all the time, water between feeds, and then of course your pediatrician, family physician, nurse practitioner, whoever needs to be sure that there's close monitoring of growth and development. And then there's laboratory, which really I would say would be to look at congenital infection. And so we won't talk more about that. Okay, what about, excuse me, a meth baby who's a toddler and is in preschool? What are you going to see? What are you going to see? Well, first of all, number one is speech-language problems. Okay. Meth babies have a lot, as toddlers, have a lot of speech-language problems. Temper tantrums. Now you say, Dr. Hoffman, wait a minute. You're talking about a 2-year-old. I mean, don't temper tantrums go along with being a 2-year-old? True, but these are beyond the pale. If you've ever seen one, you know, they can last for hours, and you begin to think, oh, is this kid going to be an adult bipolar? I mean, is this childhood bipolar disorder because of the length of the temper tantrums? And so, you know, usually a toddler, you walk away in the temper tantrum, what, lasts no more than a couple of minutes. Unless you have a strong-willed child, then that's a whole other ballgame. Aggressive behavior. Well, you say, wait a minute, a 2-year-old, I mean, aren't they pulling toys from one another and slapping each other? And, you know, the daycare sends your child home with bite marks. And so, yeah, there is some aggressive behavior in 2-year-olds, but this is beyond the pale. This is the point of becoming just a daily, hour-by-hour thing. Hitting, biting, slapping. This is the kid that comes into my office and they kick him out of daycare. All right. So this is they are aggressive. They have sensory issues. Oral sensitivity. This is the meth toddler who at 18 months of age is still on stage 1 baby foods, doesn't like the texture, is not taking Cheerios or Puffs as a finger food. They don't want to do it. Tactile. These kids are not cuddly, all right? Which I think distresses particularly some foster parents. You want to hug this kid and, you know, make them feel they do not want to cuddle. They're, in that regard, and the oral sensitivity, and then the auditory sensitivity, certain sounds just set them off into a rage. They almost look like autistic kids, really. I mean, you know, if you've ever seen or dealt with autism, the oral, tactile, and the auditory defensiveness should remind you of autism. What is the treatment? Speech therapy. Some kids will need to learn sign language. Behavior modification, so we need counseling. Occupational therapy. The occupational therapists have great little tricks on how to desensitize these meth kids so they eat food that has more texture and they're not so tactile and auditory defensive. So don't forget your friendly occupational therapist. And medications, very rarely are they used, but there's on occasion you have to use medication, particularly for the aggressive behavior. The aggressive behavior can tear families apart. You say a 2-year-old? Yeah, a 2-year-old. So sometimes you are forced to use medication. What about the school-age kid? Well, far and away, what I have seen is are problems in the area of attention, ADD, ADHD, and then the comorbids that exist. The comorbids, we mean association. There are things that are associated with ADD, ADHD, and they're called comorbids. And the most common comorbid is anxiety, and then we can see depression, oppositional defiant behavior disorder, OCD, okay? Developmental disorders such as autism spectrum and pervasive developmental disorder types of behaviors. Psychiatric disorders we start to see, childhood bipolar disorder, conduct disorder, antisocial personality, just to name a few. Academic failure. When you have ADD and ADHD, there are two common comorbids, anxiety and the other one is LD, particularly in the area of reading. These kids can't read, okay? They have dyslexia. And so that sets them up for what? Academic failure. And I put there all the above because all these things impact their academic performance and the home, okay? If you're in the home, your parents are doing meth, they're probably not going to be at PTA meetings. You know what I'm saying? All right? So the home also impacts. There again, it's multifactorial. The treatment, we like to get social services involved, counseling, PT, OT, remedial help in academics, and again, medication. This is where we use our medications for ADHD. And I just read a new article that these kids, instead of giving them monotherapy, we put them on a long-acting Ritalin. It's now suggested that we put them on a long-acting Ritalin along with a long-acting medication such as clonidine, which is used for high blood pressure, but it also can calm down what we call the hyper-aroused ADHD kid. And so I think the thinking is starting to change. We need to do dual medications on some of these kids that have been exposed to meth as infants and now are having behavioral problems, attention problems in school. Okay, now we're going to talk quickly about the acquired exposure to methamphetamine. It's called the meth home and the drug-exposed child. Meth home, the definition and environment in which a child is exposed to the use of, storing of, distribution of, manufacturing of, or sale of methamphetamine. That's the definition of a meth home. And a drug-exposed child is the child who's in that environment. Okay? The drug-exposed child, most states have their definition of a drug-exposed child. It's in the law, and I think you are more familiar with Missouri law than I am. Now, when you talk about children in the home being exposed to methamphetamine, there are unique pediatric vulnerabilities. Number one is increased minute ventilation. If I'm an adult, 72 kilograms, and I'm breathing 18 times a minute, all right, and I'm exposed to secondhand methamphetamine smoke, I'm going to get less of a toxic dose per pound or per kilogram of body weight than a one-year-old infant who weighs 8 kilos and is breathing 35 to 40 times a minute. Do you understand? They're taking in because of the rapid respiratory, they're taking in a more toxic, a higher toxic dose per kilogram or per pound of body weight. So that's a risk factor for kids. They're closer to the ground. What do 9-month-olds and 10-month-olds do? They crawl. And so where are they going to get into? Needles, glass, dirt. Lord knows what's on the floor. Okay? There's less fluid reserve. You all know that because of the increased surface area of a child per pound of body weight, and they don't have the blood volume or the intravascular volume, they're going to get dehydrated a lot quicker. And we'll talk about that in a minute. They have thinner skin. The stratum corneum, the first layer of the skin, is thin. So that has implications when you get burned, either by fire, explosion, or by a chemical burn. The burns are more extensive and deeper. A superficial second-degree burn in an adult may turn out to be a third-degree burn in a one-year-old. Large surface-to-volume ratio. That again is skin surface area per kilogram of body weight. And so if I am a one-year-old and my face is burned, say from a chemical burn from one of the precursors that are used to make methamphetamine, 9.5% of my body surface area, if I have my face burned, that's 9.5% of my body area. If I'm an adult, 72 kilograms, it's 4.5%. So you understand that because of the body surface area, a facial burn in a kid is much more serious than in an adult because 10% of the body surface area is involved. And then there's developmental issues. Kids have no sense of danger. I remember my 2-year-old, they'd run out in the street, you know, get up on the sink and jump off. And you all know parents, you know what I'm talking about. They have no sense of danger. And they can't get away from danger. You sit a 6-month-old on the floor and they can't crawl away. They're there. So that's just some of the developmental issues. Now, the types of exposure: skin contact, inhalation, ingestion, and injection. Okay. Now, we talk about exposures in terms of acute low-level exposure. This is a home, perhaps, where meth is smoked. Every once in a while, it's a low-level exposure. There's no active lab. There's no active production. And the symptoms in the child will be headache, nausea, dizziness, and fatigue. Okay? Those are some of the symptoms you're going to see. Then we go to the acute high-level exposure. Symptoms: vomiting, hoarseness, cough, chest pain, shortness of breath are the first things you see. When you see the hoarseness, cough, chest pain, and shortness of breath, you have to think of inhalation injury, okay? And there are two bad boys, as we've talked about, that can give inhalation injury in meth-exposed kids: phosphine gas, okay, and ammonia. And those two things are very caustic to respiratory mucous membranes. Increased heart rate. You would expect that with methamphetamine. It's a stimulant. You'll see the increased heart rate. But don't stop there. The heart may have been damaged further, and you may get what are called cardiac arrhythmias. The electrical system of the heart is malfunctioning, and that can lead to fainting spells and to death. And the big bad boy there is phosphine gas, very toxic to cardiac tissue. In fact, and here's a take-home message, if the child has been exposed to phosphine gas during the manufacture of meth, and they have heart rate, they have irregular heart rate, irregular heartbeat, they have an arrhythmia, that child should not be left alone. They obviously need to be hospitalized and monitored, because these kids can develop congestive heart failure a day or two later. So you never take your eyes off of that type of symptom. Dark urine indicates kidney damage, jaundice obviously liver damage. There can be skin and eye irritation, decreased coordination. They stagger like they're inebriated, which many times they are. Hallucinations and death. Those are the acute high-level exposures. Chronic exposure. Up front, the data is unclear as to what are the definite long-term effects of chronic exposure to methamphetamine and its precursors, the vapors from its precursors. So I can't say anything definite here. The data is just not there. But we suspect there's going to be damage to the CNS. We're starting to see that in school-age kids with the ADHD and all the other mood and behavior disorders. So we suspect that long-term we're going to see that. We can say the data is pretty clear that you're going to get, with chronic exposure, long-term exposure, liver and kidney damage, no question about it. On paper, we should see decreased immune system function. These kids should get more infections, for instance. And we should see cancer cropping up. But the data is just not there yet. And I think we just haven't watched these kids long enough to get a feel. But those are the things we worry, especially cancer. We're really worried about what's going to happen when these kids are in their 40s and 50s and beyond. Genes. Okay. Some of those things that kids are exposed to in the meth home have been associated with genetic breaks. And are we going to see kids of meth kids have genetic anomalies? It's like acid, all right? The acid that was smoked in the 60s, that has caused genetic abnormalities in the offspring. Fire and explosions, won't belabor that point. 15% of all labs are discovered by fires and explosion. And with the shake and bake method now, it's probably higher than that, because that's a very dangerous way to make meth. There's increase in physical abuse and neglect, and no surprise there. I'm sure you guys see that all the time. A parent who is high on meth is not a good parent. Child's needs are neglected. There's physical abuse. I read one case where a parent slept for days and didn't feed their kid. They were just out. They came down off a high and they were just sleeping. And did you see that in the news where this mother took her 19-year-old autistic son out to a field? She fell asleep, I guess, or was out of it, and the kid starved to death, I guess. Or I don't know if she did physical harm or not. But anyway, it just makes the point. Increase in failure to thrive. These kids don't get fed, they don't grow. So we've got to watch that. And then the decreased rate in immunizations. It was really interesting in the early 2000s, maybe the late to mid 90s. I don't know if you all remember this. Some of you are little, probably won't. But there was just a rash of cocaine babies. I mean, in 1 2-week period, I had 6 cocaine babies in my practice. And it was really interesting. When we kept an eye on these kids and called the mothers up and made them bring the kids in, they did beautifully. They got their shots and everything was fine. After 6 months, after they got out of the halfway house, generally, guess what? You never see them. So kids in meth homes do not get immunizations. Physical hazard, guns, tripwires, explosive, poor ventilation. I am told that meth labs, the windows are taped because they don't want people to smell the smell, and they don't want prying eyes in the window. And so you can imagine a taped up house or a room in southeast Missouri summer, and guess what? It's going to, kids are very vulnerable in that situation to heat-related illnesses. So you'll see kids that have heat-related illnesses, heat, exhaustion, heat stroke. Needles, and then poor sanitation. Go self-explanatory. Social problems. Due to the chronic neglect and violence and chronic chaos, the number one thing we see is anxiety. And remember, in kids, anxiety may look like ADHD, right? So you see a kid looks like ADHD, think of anxiety. It's either associated, they may have ADHD and it's associated, or they may just be anxious. We also see in the meth-exposed kids, we're starting to see some depression, post-traumatic stress disorder. You all know what that is. Okay? We're starting to see that in children. And in the school-age kid, it looks pretty much like the adults. The recurring thoughts, the recurring dreams, the avoidance of situations or places where perhaps abuse has occurred in the past. They're withdrawal and just do not do well academically. There's an increase in attachment disorder. You know, for the first 20 years of my practice, maybe 25 years, I never saw a case of attachment disorder. And then I started to get interested in international adoptions. And lo and behold, I would see international adoptees coming from particularly Eastern Europe and Russia. And these kids were left as infants, no meeting of their needs in any way, no tactile stimulation. And all of a sudden, I started to see quite a few attachment disorders. And we're starting to see attachment disorder in meth babies because they were neglected as infants, and you start to see this around 3, 4, 5. They start to develop signs and symptoms of attachment disorder. They are withdrawn, sullen, violent, particularly against their parents. They are liars, they steal, and are just very difficult kids to parent. So something we need to tell our foster parents. If there's been a lot of neglect in the first couple of weeks to couple of months, be aware that attachment disorder could occur. We're seeing ADHD-like symptoms, oppositional behavior, and violent behavior also in kids exposed to the meth home. And finally, there's academic failure, either directly from CNS insult from the meth exposure or lack of emphasis on academics in the home. Treatment of the drug-exposed child, it has to be a multidisciplinary approach. I hope you've gained that as I've talked. One person can't do this. It requires a whole cadre of organizations and people. The first thing you're going to do is immediate removal of the child from the home. And of course, that would involve the police, social services, the courts, foster care. I want to say just a word about decontamination. I don't know if you'll get involved in that or not. But the first thing after the child is removed from the home, the clothes have to be taken off, and the baby or the child has to be given a bath in hot water with soap. Okay, so soap and water are what you need to decontaminate. The clothes probably ought to be burned or destroyed or because they're contaminated. Now, one other thing about decontamination I want to talk about, toys, all right? You have this meth kid who's 2 and has been traumatized with chronic chaos, violence, neglect, and the one thing in his or her life that she holds on to or he holds on to is what? That teddy bear, okay? And the teddy bear, you know, is full of what? Contamination. So you've got to make a decision, right? Is it better to wash the teddy bear, soap and water, and leave it with the child versus saying that the teddy bear is so contaminated, we don't want further contamination, you throw the teddy bear away? Well, my own personal feeling is, if at all possible, keep the teddy bear. Okay? Now that's not always possible. Other toys, trucks, other toys where there's cracks and crevices, it's a no-brainer. You've got to get rid of them. But teddy bears, I would make an exception. Okay. Let's see. We talked about police, social services, courts, foster care, medical follow-up. I mean, when do you take a child that you removed from the meth home? When do you take them for medical care? If they have no symptoms, okay, even if they test positive for meth, what I hear, and I've looked at several state protocols, is that you probably ought to have them seen by a doctor within 2 days, okay? Within 48, maybe 72 hours. If they are symptomatic, they need immediate medical attention. If they have cough, hoarseness, eye irritation, tachycardia, rapid heart, any of those things, dark urine, you've got to get them seen. Also, in terms of medical follow-up, when should, of course, you're going to get a drug screen. When should you get, I don't know what you guys do for drug screens. I was always taught 8 to 12 hours. You have 8 to 12 hours to get a urine drug screen. Now, if it comes back positive for meth, don't put your eggs in that basket, because there's a high incidence of false positive meth values on a urine drug screen. You've got to go for the blood test, okay, and which is the urine drug screen is qualitative, yes or no. The blood test, the gas chromatography, etc., that is quantitative, and that's what you want. You really want that test, and you have 2 days to get that. 2 days. Okay. Other medical follow-up just depends on the child, the history, the physical. Do you need a chest X-ray? Do you need other lab? Looking for other, and your history and physical will guide you in that. Counseling, an absolute must, and that's anything from psychology up to psychiatry, PT and OT. Certainly, you have to make sure you get your physical therapist and occupational therapist involved, because these kids do probably have problems in the areas of motor skills and fine motor, gross motor skills, etc. And then educational services, because I'm sure they're going to be behind in terms of where they should be academically. Okay, and I'm going to end with this, the long view. Okay, limited data on the meth-exposed kid long term. We just don't know, because the problem hasn't been around long enough for us to, I mean, in a big way, for us to decide what to do. Theoretically, cancer should be occurring more frequently in meth-exposed kids. There should be some metabolic problems due to the liver involvement. Are we going to see more diabetes, more cardiovascular disease? We don't know. Endocrine, is there more thyroid disease? We just don't know. CNS, we're starting to see some preliminary data that these kids are going to have mood disorders, attention disorders, and maybe even beyond that, bipolar and psychoses, and genetic. Interestingly, there's some studies out now that suggest that if you have one or more meth parents, guess what? They're starting to think that there is a meth gene that will increase your likelihood of getting addicted. Okay. So that needs to be fleshed out. And of course, if a parent uses meth, do they pass bad genetic material on to their offspring? And I'll end right there. Thank you for your attention. And any questions? Any questions? Yes?
I have a lot of parents telling me that there's no way their child can test positive for meth because they use IVs.
They do what?
Because they use the needles
that's the most accurate. If you're looking for a qualitative test, hair follicle analysis is even more accurate than urine. Okay, so they really don't have a leg to stand on. And then if you do the, the GCMS blood test, yeah, you'll catch it. So no, yeah. Yeah. I saw another hand here. Okay. Any other questions? Okay. Yes.
What would you consider chronic? The chronic longevity.
The chronic.
How long is that?
Yeah. Generally, I think if the kid has been in a meth home for 4 to 6 months or beyond, okay, that to me is a chronic exposure. And you've seen kids that have been in a year, 2 years, 3, 4. It's horrible. Any others? Okay. Thank you for your attention, and thank you for having me talk.